Hello, everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein, and shortly we'll be going to Dr. David Reznik for his update on the pandemic and how it's affecting dentistry. But I wanted to make sure you stayed tuned to the very end because I have a couple educational opportunities to share with you. But now, Dr. David Reznik.
Thank you, Gary. And as always, it's a pleasure to join everyone and give you an update on some of the latest information that we see regarding COVID and its impact on dentistry and how we are moving forward. It's a special time of year. We're getting ready for Halloween and Thanksgiving and Christmas and things of that sort. So what do we know? What can we move forward with? And what exciting information do I have to share? And there is some exciting information to share today. So let's go to see some of our epidemiological areas. Where are we with the COVID-19 tracker? We have over 8.5 million cases, plus 83,000 new cases. In the last 7 days, we've had over almost 6,000 deaths in the last 7 days, and the total deaths are over 225,000 at this point. If we really look at how bad the last 7 days have been, there have been 500,000 new cases and 5,600 new deaths in the latest data that I have. And so still a serious illness, still something that we need to take our guard up on. But I'm having patients who are telling me that they feel more safe in my office because of all the precautions we've taken that they do when they go to a grocery store or they go to pick up something at a little shop. And so I think we need to start getting that message and really pushing that message on how well we're doing to protect our patients and our staff. If we look at where the reported cases are over the last 7 days, the darker of the parts on the map that you see are the cases that have the higher numbers, between 16,000 and 23,000. And you can see New Jersey has shown back up. We have issues in Florida, Texas, and California. I think we've all heard on the news about issues that they're having in Utah with an outbreak there. Regretfully, Georgia is starting to see an uptake again in cases, and we had it under control for a period of time, but that seems to be reversing now. But our hospitals are full. And as you know, I do work at a very large hospital system, and we have been packed, and not with COVID cases. We have been packed with trauma cases. We have been packed with other illnesses that maybe people were putting off and not getting checked. So it's really important when we do see our patients that we push that whole concept of total health, that they're coming to see us. We provided a very safe environment. And please make sure if they have hypertension or they have underlying conditions, that they're receiving or obtaining the proper medical care that they need. If you look at the total number of COVID-19 cases reported to the CDC, again, you can see the higher numbers of 762,000 to 886,000. That hits states like Florida, Texas, and California. But you can also see that the Northeast and parts of the Southeast have had significant impacts. And if you look, the only state on the map that seems to be doing somewhat well is the state of Wyoming, where, like as I said before, I have some dear friends and family. If you look at COVID deaths in the last 7 days, as reported to CDC, again, these numbers or the states shouldn't be a surprise. You have more cases in Florida, Texas, and California. You're going to see more deaths in those states. You can see the Southeast once again, in the Mid-Atlantic area is seeing a jump, as well as the Midwest. And we've talked about some of the issues that the Midwest has been facing, and now New York is actually starting to see a tick up, and we've heard about some of those on the news as well. If we look at the total number of deaths in the United States, again, those 3 states, now we have an increase in Utah, Georgia, significant, Louisiana, New York, etc. And the total number of deaths, again, look at New Jersey. So we don't have this under control. We still have a problem. This epidemic is going to be with us. And let's go into some of the data on who is getting infected by this, because we can literally look at cases reported by race and ethnicity. And you can see If you look at the percentage of total cases, you can see that Black non-Hispanics make up 18%, Asian non-Hispanics 3.3%, Hispanic or Latino almost at 30 or almost at 29%. That's a significant number. White non-Hispanic at 44%, 43.4%, Native Hawaiian, other Pacific Islanders 0.4, and multiple 4.6. So you can literally see this track on who is getting infected, and those are the numbers that you're going to see that have complications later on. If you look at adjusted rates for hospitalizations by race ethnicity, you can see that there's been a significant impact on the Hispanic Latino population, the non-Hispanic Black or African American population, and the non-Hispanic American Indian and Alaska Natives. So as when you look at the percentage per 100 population, you can see how negatively this is impacting some of our racial and ethnic minorities across the United States. Excessive deaths. So when we look at this, what has been the impact of COVID on the number of deaths one would expect during the course of the year in the United States? As of October 15th, deaths due to COVID have been reported. However, there might be an underestimate because we don't really have all of the cases. If somebody has a heart attack and they have COVID, it's not going to be listed normally as COVID. So what does this report actually show? An estimated 300,000 excess deaths occurred between January and October. 66% or almost 200,000 excess deaths are attributed to COVID-19. So we do know this has had a negative impact as far as mortality. The largest percentage in increases were seen amongst ages 25 to 44. We're not talking about people my age and older. We're talking about people younger, and also amongst people of Hispanic or Latino ethnicity. Again, 2 out of 3 of the excess deaths were people who are Hispanic or Latino and adults aged 25 to 44. So I remember at a point when I was young that you sort of feel that you're invulnerable. This isn't going to impact you. Regretfully, this is impacting all of us. And so we all must take the safety precautions that we do in the dental setting and really make sure that we translate this into our everyday setting. Because one of the concerns we have in a hospital setting or in a clinic environment or a dental office environment is what happens when people aren't at work, your staff aren't at work, and what they can possibly bring in. If I look at our hospital, if you look at the number of tests and positivity rate, it's about 2.6 on staff. So, I mean, there are life events, there are things that happen there. And so we really need to do our best to try to control this epidemic until we have good vaccines and really great therapeutics. If you look again at excess deaths reached their highest points at 2 points this year. We had that big bump in July of cases. And so, in March in cases. So we had a big bump in April in the number of excess deaths on April 11th. And we had that big bump in the July cases. And then on August 8th, you can see again, we had another wave or another big bump of cases where people were dying from this pandemic. Regretfully, at a nursing home that is in my home city, they've had an outbreak now, and we thought we had some of those nursing home issues under control with over 50 people being infected, and we've had a significant number of deaths, and then 3 staff people as well have been infected. So we still need to take all those precautions necessary. The total number of excess deaths from this period of time, from the end of January through the beginning of October, went from a low of approximately 841 in the youngest age groups, those less than 25, to a high of almost 95,000 amongst our senior adults, age 75 to 84. The average percentage change of deaths over this period compared with previous years was highest on the younger group, the people aged 25 to 44. It was almost a 26.5% increase. So although more excess deaths have occurred amongst older age groups relative to past years, adults aged 25 to 44 have experienced the largest average percentage increase in the number of deaths from all causes from January through October. When did this age shift happen? Well, it looks like it happened between May and August. However, the disproportionate increases might be related to underlying trends and other causes of deaths. So amongst racial and ethnic groups, the smallest average percentage increase in the number of deaths compared with previous years occurred amongst white people, about 12%. The largest was Hispanic persons, which I've talked about, 53%, almost 54%, with intermediate increases amongst African Americans, Black, and Asian persons. The disproportionate increase among certain racial and ethnic groups are consistent with noted disparities in COVID mortality. So this is not new information, it's just giving this information in a different form for you. Good news. I always like to give the good news because when we're talking about death rates and excess death rates, that's not good news. But what we do know now is studies have pointed to a significant drop in COVID-19 death rates. And that is wonderful. There's 2 new peer studies that are showing a sharp drop in mortality amongst hospitalized COVID-19 patients. And this drop is seen in all groups, including older patients, including those with underlying medical conditions. And what it suggests is it's the practice of medicine. We actually know what's presenting now. We know how to deal with the cytokine storm. We know how to deal with some of the breathing issues that we had before. We have treatments now. We have steroids that are being used. And so at the beginning, we really were sort of clueless. Now, based on experience, the results are getting better. And so the death rate is dropping, and it's dropping significantly. One of the studies was actually published out of NYU Langone's hospital system. This Dr. Horowitz, she found, again, on one of her studies, showed that the death rate went down substantially. And New York University is an enormous hospital system, so they have a significant number of people that they can follow. They looked at thousands of patients between March to August. It was a single health system, so that always adds some variety to it. It finds that mortality has dropped among hospitalized patients by 18 percentage points since the pandemic started. So at the beginning of it, if you were hospitalized, you almost had a 26% chance of passing away. At the start, now it's down to a 7.6% chance. 7.6 is still too high. But with the decrease from 25.6 to 7.6 is remarkably important, but still, I want to get the point across, it's still a deadly pandemic. But when you look at this compared to other diseases, it's still significant. The death rate is higher than those, including the flu. There's sometimes confusion about what is more deadly. Is it COVID-19 or the flu? The flu does not have a 7.6% death rate at NYU Langone. Those who can recover can still have complications for months or even longer. There is a percentage of the patients who do have symptoms that persist for quite some time. It still has potential to be very harmful in terms of long-term consequences. So again, the best thing to do is to avoid getting the infection in the first place. The second best thing to do is to avoid going to the hospital. The people who are getting hospitalized now tend to be much younger. They also tend to have fewer underlying diseases. They tend to be less frail, but they're still ending up in the hospital. And this is compared to people who were hospitalized earlier parts of the epidemic. So they looked at more than 5,000 hospitalizations, which again is significant. They adjusted for factors including ages and other diseases such as diabetes to rule out the possibility that the numbers had dropped only because younger, healthier people were being discharged. They found the death rate dropped for every group, even older patients by 18 percentage points on average, which is remarkable, which shows the advances in medicine, which is really, truly significant in this point. Dr. Mateen, who's a science fellow at the Alan Turing Institute in the UK, also conducted research of 21,000 hospital patients cases in England. Found a similar sharp drop. So it's not just in the United States we're seeing this drop, we're also seeing it in Europe and UK. This publication, which will be seen in Critical Care Medicine, was released early in a preprint, which is what I had access to, shows an unadjusted drop rate in death rates amongst hospital patients around 20 percentage points. So somewhat similar to what we're seeing in the United States, a little bit higher since the worst days of the epidemic. So we're really seeing a significant drop in the death rate, and that is excellent news. One of the reasons that we have this is we do have our first treatment approved by the FDA, Remdesivir. It approved Remdesivir as a treatment for hospitalized patients aged 12 and up, making it the first and only FDA-approved treatment. The FDA did give an emergency use authorization of the antiviral in May that allowed the drug to be used only for patients with severe COVID-19, specifically COVID-19 with low blood oxygen levels or pulse ox, and those who needed oxygen therapy or mechanical ventilation. The approval was based on 3 randomized controlled trials. I'm sure you've heard that over the news for some time, but a randomized controlled trial is going to have certain people are going to get the medication and others are going to get a placebo. And what did we find? So the background on one of these trials that's in the New England Journal of Medicine that was published earlier this month, although several therapeutic agents have been evaluated, no antiviral agents have been shown to be efficacious. This is why they did the study. They conducted a double-blind, randomized, placebo-controlled trial of intravenous, so this is an IV medication, remdesivir in adults who were hospitalized with COVID-19 and had evidence of lower respiratory tract infection, so a lower lung infection. Patients were randomly assigned to receive either remdesivir, a 200 milligram loading dose on day 1, followed by 100 milligram daily for up to 9 additional days, or placebo for up to 10 days. The primary outcome was the time to recovery, defined by either discharge from the hospital or hospitalization for infection control purposes only. The results of the 1,062 patients who were in this trial, 541 who were assigned to the remdesivir level, 521 to placebo. Those who received remdesivir had a median recovery time of 10 days as compared to 15 days amongst people who received placebo. So it did get you out of the hospital sooner. So I want to stress this, that if you were on the remdesivir arm, your recovery time was 10 days. If you were getting the placebo, the recovery time was 15 days, significant. The conclusions, the data shows that remdesivir is superior to placebo, and that's why we do these placebo-controlled trials at shortening the time to recovery for hospitalized patients with COVID-19 that had evidence of lower respiratory tract infection. However, and this is important too, there was not a statistically significant difference in mortality between the treatment and placebo groups. So we're doing better with our management. We also have other information that's out there, like I said, about the cytokine storm, which causes this significant inflammatory reaction. But we do know now that we have a medication that can reduce the hospitalization time, and that is remarkably wonderful. So let's go back a little bit on some of the key considerations for modes of SARS-CoV-2 transmission. Person to person is the predominant role. We know that, likely via respiratory droplets for coughing, sneezing, or talking. You could add singing. High viral shedding event in the upper respiratory tract, so a higher viral load. Airborne transmission has been suggested by multiple studies, but frequency is unclear in the absence of aerosol-generating procedures. Remember, we still have some unanswered questions, and those are things that are being researched and things that we'll bring to you as soon as we have the information. We did find out that the virus was rarely cultured in respiratory samples greater than 9 days after symptom onset, especially in patients with mild disease. Multiple studies describe a correlation between reduced infectivity with decreases in viral loads and rises in neutralizing antibodies. So the more virus you have when you cough or you sneeze, the more likely you could transmit. Though if you do have neutralizing antibodies, you're going to have a less viral load. If you have a milder disease, you could have a less viral load. And so these are factors that go into transmission. And the American College of Obstetricians and Gynecologists found that data indicate that vertical transmission or mother-to-child transmission during birth appears to be uncommon. So that's excellent news for pregnancy. If you look at 172 studies investigating the spread of SARS-CoV-2, SARS, and MERS, face mask use, surgical, N95, or cotton mask, result in large reductions in infections. Association was stronger, of course, for N95 or other respirators versus disposable or 12 to 16 layer cotton masks, which is why when we're performing aerosolized generating procedures in the dental setting, if we need to, we have on N95s as a minimum part of our PPE. And when you look at studies of human coronavirus exhaled breath in children and adults with acute respiratory illness wearing surgical face masks wearing no mask, virus was detected in respiratory droplets in 3 of 10 samples collected without face masks versus 0 of 11 samples with a mask. So it was significant. Virus was detected in aerosols in 4 of 10 samples collected without face masks and 0 of 11 samples with a mask. Again, significant. So it's really important to mask. And whether you're at work, which is always important to take your proper PPE and do your proper precautions, or whether you're going to the grocery store or you're going to be out in public. I've shown this slide before, but I always like to remind people and use 3 different examples of basically that say the same thing. If someone has COVID, and they're not wearing a mask and they're within 6 feet and they're talking loud and there's a person that has a mask, there's still a significant chance that the person who is masked can be infected, up to 70% chance. If the person with COVID has a mask on and you don't, which I don't recommend, the reduction goes down to 5%. So that mask really does help prevent, if you have the illness, it protects others from you. If everybody is masked, then we don't have this epidemic going along that much because it goes down to 1.5%. So again, repeating, if you don't have a mask and you have COVID and you're around people that do have a mask, you can still infect people up to 70% of the time. If you have COVID and you wear a mask and you stay at home and do what you need to do, and somebody comes in and you talk to them and they don't have a mask on, the probability goes down to 5%. And if everybody is masked, the probability is 1.5%, which is greatly reduced. The CDC has changed their guidance on what they mean by 15 minutes. If you remember early on, it was within 6 feet and having 15 continuous minutes of talking to someone who had COVID. And so they decided they needed to clarify what they meant by close contact when it comes to transmission of SARS-CoV-2. The previous guidance suggested that close contact would have to be in those 15 direct minutes. But now, based on other cases, we acknowledge that even brief contact can lead to transmission. Specifically, the new guidance suggests that those spending a total of 15 minutes of contact with an infectious person over the course of a 24-hour period should be considered in close contact. So it could be and I think this happened to do with in a jail environment where somebody who worked in the jail was exposed on multiple times during a 24-hour period of time, but not for very long. And so again, mask to protect yourself. Everybody should mask. So what do we know about infection prevention? I think dentistry, we started off with great preparation. We've been using standard precautions since the beginning of the HIV epidemic or pandemic. So healthcare personnel that are caring for patients with suspected or known COVID-19, again, for routine patient care, masking, N95s, make sure it's an fit-tested N95 or surgical mask. So you have your options there. But if you're doing aerosolized generating procedures, you should always have on an N95 or greater that has been fit-tested for you. In a crisis setting where we're running out of supplies, where the whole country is being hit at the same time, or possibly a state might be running out of supplies for routine care, surgical mask or N95, a face shield or surgical mask covering the N95 to allow for extended use or reprocessing. And we can reprocess our N95s using UVC as one of the ways. We're looking at getting an oven in here where we can reprocess masks if the need arises. Presently, we're doing fine with our PPE because I'm in a hospital-based program, but for those who don't, you can reprocess your N95s for up to 4 to 5 minutes. So the preferred PPE that we would wear in the dental setting is always going to involve a face shield, an N95, or higher for respiratory protection. one pair of clean gloves. There has been no documentation or no evidence that you need to double glove for this patient population. The Infectious Disease Society of America has not given any notification that footies are protective. So at this point, we really are going by the CDC guidelines, which the Infectious Disease Society of America does agree with, that face shield, N95, gloves, and disposable gown, isolation gown. If you're running out of N95s or you have asthmatic staff that can't wear them, a level 3 surgical mask under the shield should be fine. One pair of clean gloves and, of course, a disposable gown. Something that comes up that I think confuses people on occasion is, what is the R number? I mean, these are things that we really don't deal with much in dentistry, but what is the R number? Well, it's the effective reproduction number, and basically, to put it, it's a way of measuring the infectious disease capacity to spread. So an R number signifies the average number of people that one infected person will pass to. The R number isn't a fixed number. It's a number that can go up. It's a number that can go down. It's affected by a range of factors, including not just how infectious a disease is, but how it develops over time, how a population behaves, or in some cases misbehaves, and any immunity already possessed thanks to infection or vaccination. Location is also important. A densely populated city is likely to have a higher R than a sparsely populated rural area. Because SARS-CoV-2 is a new pathogen, scientists at the start of the outbreak were scrambling to figure out what this R number was, or R naught. The virus's transmission among a population that has no immunity. So this was a new disease. As we all know, we don't have immunity to it. And so they were looking at the R naught. What is the transmissibility of this infectious pathogen, the virus's transmission among a population that has no immunity? Studies on the early cases in China indicated that the R naught was between 2 and 2.5. More recent estimates have placed it as high as 6.6. To put the figures in context, the R naught is worse than seasonal flu. There are some people who say this is as bad as flu. It is not. Flu has an R naught of about 1.3. So if you're not vaccinated for the flu, then you will infect more people. But significantly better than measles, which is a highly contagious disease that everyone should be vaccinated for, which their R naught is between 12 and 18. So that is significant. But we have a vaccine for measles, so the effective reproduction number for measles is way below 1, because we do have the ability to get immunity within the population. An R of less than 1 means that the virus will eventually peter out, and that's something that we're all hoping for. We're not there yet, but something that we're all hoping for. The lower the R, the more quickly the virus can go away. An R of 0.5 means that 100 people would infect only 50 people, who would then infect only 25 people, who would then infect only 13 people. So you can see the pathway is going down. As the number of cases drop and ill people either pass away or recover, the virus will be brought under control if the R can be kept low. What makes me excited is, what role can we play in the dental healthcare profession to help get that R number down? What can we do to help identify people? There's still issues with testing in certain parts of the country where people aren't able to access testing. And I'm very proud to say the American Dental Association House of Delegates on October 19th said that dentists can play a larger role in the early identification of possible medical conditions, including COVID-19. In patients by utilizing point-of-care screening tests. And this is something that I have really championed for quite some time in my own field in HIV, of getting dental healthcare providers to screen for HIV as a part of routine dental care. Of course, that was a bigger challenge because of the stigma associated with HIV is significantly less than the stigma associated with COVID-19. So point-of-care testing is supported by the American Dental Association. Resolution 22H-2020 provides dentists another mechanism to assess the relative risk or benefits of providing dental care when patients with medical comorbidities or even clinical evidence that indicate a possible underlying diagnosis. The American Dental Association, in consultation with its Advisory Task Force on Dental Practice Recovery, released in October the COVID-19 and lab testing requirement toolkit to help guide dentists interested in offering their patients a rapid response point of care COVID-19 testing within their practices. So as someone who truly believes in the integration of medical and dental care, this is a big step forward. I'm actually proud to say that the sponsors of these talks today is offering a comprehensive suite of rapid point-of-care diagnostic testing solutions for the dental setting. So you can actually ask people about this. It's exclusively distributed through Henry Schein. It's Q Health's COVID-19 molecular rapid test and enables you to test patients and staff. It has 99% sensitivity, which is a remarkably high accuracy, very low occurrence of false negatives. Average was 98.7 across 4 clinical studies. So this is documented clinical studies that have shown the sensitivity of this Q test. 98% specificity. So this is a low occurrence of false positives. So you have the average was 97.6 across 4 clinical studies. So we have high sensitivity, we have high specificity, and we have a rapid point of care test that we can actually begin to implement in the dental setting to really help our communities, to help our patients, to help our staffs. So you can actually find out more about this, looking at the email, it's dentaldx@henryschein.com. I do not normally promote products. That is not something that I do. But in this case, since we have something that the dental community can access, and there's a toolkit put out by the American Dental Association on a way that we can help not just deal with oral disease and oral health, which we know you can't be healthy without oral health, but we can play a larger role in containing this pandemic. I am all for it. So please look at this slide, call your reps, call this information on dental, or email this information on dentaldx@henryschein.com, and hopefully in the future we'll be covering more about this as we move on. Another remarkable event, which, I find these events, as someone who has championed medical dental integration since almost the beginning of my career, and I'm still well into my career, I am just overjoyed that the ADA supports efforts to allow dentists to administer vaccines. Even before COVID, I've been concerned about giving vaccinations for human papillomavirus, which is the big cause of head and neck cancer and cervical cancer and other different kinds of cancers that we can prevent. And so having dentists the ability to give vaccines for that, as well as when we do have an FDA-approved vaccine for COVID-19, again, a lot of people come to the dentist in the course of a year who do not see our medical colleagues. So for us to be able to offer a vaccine, for us to be able to offer point-of-care testing, is remarkable advances in dentistry that I am so glad I'm here to participate in. So the ADA House of Delegates passed a resolution on October 19th that expresses the ADA's support for dentists who are seeking to administer vaccines, including, when it becomes available and FDA approved, a safe and effective vaccine for COVID-19. Resolution 91H-2020 states that dentists have the requisite knowledge and skills to administer critical vaccines that prevent life or health-threatening conditions and protect the life and health of patients and staff at the point of care. Dr. Ho, chair of the ADA Council on Dental Practice, said the pandemic has highlighted the potential benefits of an expanded role for dentists in preventive healthcare, which we have always been involved with, preventing oral diseases, now preventing systemic diseases, including access to and the administration of vaccines. So things that we do, we have patients in my part of the country that have hypertension. I'm sure you do too, which is why we do simple things like taking blood pressure. And if the blood pressure is out of control, we refer to the medical setting. In this case, we have the ability to do point of care testing for COVID. And you've seen lines for people trying to get tested or different issues that people are having around the country with access to testing. Imagine the benefit if dental offices were able to offer point of care testing and how fabulous that is. And when we have a vaccine, instead of having to wait to see your doctor or go into a crowded facility, you know that dental offices are taking infection control to the nth degree. So it's a safe environment to get your point of care testing and move forward. So I'm very proud of the profession. These are new things for us that will move through, that will bring oral health and primary care even closer together because we have all of the scientific data showing the inflammatory processes of the oral cavity, how it impacts the rest of the body. So as always, it's been a pleasure. I'm so happy to be able to share some positive news on the point of care testing and vaccines as we move forward. It's an important time for us to take all of our safety precautions. Don't let your guard down now. There will be family events that we will attend and things that we're going to be around. So please make sure you protect yourselves, you protect your loved ones, and protect your wonderful practices. Communicate to your patients all of the different steps that you're employing to make sure that they have the safest dental visit possible. So thank you again, and I'm going to turn it back to Gary, as always. Bye-bye.
Thank you, Dr. Reznik, for sharing all that vital information on the pandemic and how it's affecting dentistry. And certainly we can see the passion you have in making dentistry a vital part in controlling it. And now I'd like to share with you some upcoming educational opportunities, both in digital dentistry and in infection control. If you're watching this video on the premiere date, then Dentsply Sirona World 2020 is only 2 weeks away. And as you might know, it's going virtual this year. So from November 13th to the 20th, you can experience it. And Dentsply Sirona has put together over 70 hour-long courses covering 12 different tracks that you have access to. And if you choose to, you can get up to 50 hours of CE. And often it's presented by some of the leading opinion leaders in dentistry and business and in other areas. So I'm certain that you see some of the people that are familiar with you or read the names. Also, on the keynote address, you can have an exclusive access to Simon Sinek's presentation. So great opportunity to learn more. Now, if you choose to contact Henry Schein and join a FastPass track, which means you have complimentary access to all of those videos for that week, we also include a customized program for you in both CAD/CAM and or 3D. So if you're new to CAD/CAM, there's a track for you. If you're a CAD/CAM owner and want to upgrade technology, we have a track for you, as well as 3D, new and owners. If you're interested in getting complimentary access to this as dentists, go to henryscheindental.com/fastpass or check with your local Henry Schein representative. Now, registration on DS World closes November 9th, 2020. So please either go to the website and see if you qualify or contact your local Henry Schein representative. And then OSAP, one of the leading infection control organizations in dentistry, is putting on a COVID-19 webinar series from November 6th on to January 8th. 4 different programs presented by Eve Cooney and Kathy Eklund, both premier presenters giving you information on respiratory protection, PPI optimization, guidance for dental assistants, as well as airborne precautions. So take advantage of that by going to osap.org and registering. If you had any comments, questions, or concerns, please email us at webinars@henryschein.com. Please subscribe to our YouTube channel by clicking the subscribe button. As always, until we see you again, stay safe, stay informed. Happy Halloween. We'll see you shortly.